Hey everyone, and welcome to today's Explainer. I'm really excited to dive into this one with you. We're going to be looking at a hidden, almost microscopic battleground that honestly affects millions of people every single day. We'll be unpacking the pathophysiology, the absolute detective work behind the diagnosis, and the pretty incredible modern arsenal of treatments we now have for rheumatoid arthritis, or RA.
So just think about this for a second. What if your body's defense system, the exact thing designed to protect you from bacteria and viruses, suddenly got confused and just mistook your own joints for the enemy? Well, that is the terrifying reality of rheumatoid arthritis. This is definitely not your standard wear and tear joint pain. It's an internal, totally invisible conflict where friendly fire ends up causing devastating collateral damage to the synovial tissues of your joints.
Okay, so here's our battle map for today. We'll kick things off with the invisible joint war, move right into detecting the disease, and then look at our first-line defense, which are DMARDs. After that, we'll cover precision strikes with biologic therapies, managing the crossfire, and finally, wrap up with the treat-to-target strategy. Let's get right into it. Part 1, the invisible joint war. Let's talk about exactly who gets caught in the crossfire here. RA is actually one of the most common autoimmune diseases out there. If you look at the data, it affects roughly 0.5% of the U.S. adult population. Now, 0.5% might sound like a tiny drop in the bucket, right? But when you scale that up, you realize we're talking about literally millions of individuals navigating chronic pain, joint stiffness, and systemic inflammation every single day. And when we look at external risk factors, genetics obviously play a massive role here. Like, if you have an affected sibling, your risk jumps up significantly. There's also a pretty stark demographic divide. Women actually have a 3.6% lifetime risk compared to just 1.7% for men. But you know what really surprised me? The environmental triggers. Get this. Cigarette smoking almost doubles your risk of developing RA. I mean, wow. Add in other factors like obesity, diet, and even occupational silica dust exposure, and you have a perfect storm that can provoke the immune system into this totally confused state. So once that trigger gets pulled, a pretty devastating immune cascade kicks off. First, your T cells, think of them as the generals of your immune system, activate abnormally. They start barking orders by sending out chemical signals, specifically inflammatory cytokines like interleukin-4 and interleukin-6. These signals then recruit B cells, which differentiate into plasma cells, and the whole thing ultimately leads to the degradation of your joint cartilage and the resorption of bone. Basically, your immune system is actively recruiting an army to dismantle your joint from the inside out. All right, moving on to section 2, detecting the disease. How did doctors actually figure out this invisible war is happening? Well, if you've ever read up on RA, you've probably heard of rheumatoid factor, or RF. It's a blood marker detectable in the vast majority of RA patients, roughly 75%. But here's the catch. It is not a perfect test, at all. Rheumatoid factor can actually show up in the blood of completely healthy people or folks dealing with other totally unrelated chronic infections. So doctors really need a much more specific clue to nail down the diagnosis. And that brings us to ACPA, anti-citrullinated peptide antibodies. This is just an incredible piece of data right here. ACPAs can actually be detected in a patient's blood up to 15 years before the onset of any clinical RA symptoms. Honestly, just let that sink in for a second. 15 years. This proves that the disease is actually simmering right beneath the surface, with immunologic activation quietly building and building, long before your first joint ever aches or swells. Which leads us to section 3, first-line defense and the deployment of DMARDs. See, the ultimate goal here isn't just to cover up the pain. It's to physically stop the joint destruction in its tracks. And the primary anchor for this defense strategy is methotrexate. For new patients dealing with moderate to high disease activity, methotrexate is the highly recommended first-line synthetic DMARD. Why? Because it actively slows or even halts the radiographic damage to the joints. Plus, it has decades of well-established efficacy behind it, and it's highly cost-effective. It's a real workhorse. But of course, methotrexate isn't the only weapon in the armory. If a patient has lower disease activity or, if methotrexate causes side effects they simply can't tolerate, which definitely happens, doctors have alternative conventional DMRs ready to deploy. For example, hydroxychloroquine, which is an anti-malarial drug, is actually preferred for milder cases because of its pretty favorable side effect profile. Then you've got sulfasalazine and leflunomide as well. And sometimes, if things are stubborn, doctors will use a triple therapy approach, combining methotrexate, sulfasalazine, and hydroxychloroquine to just hit the disease from multiple angles all at once.
All right, let's step it up a notch with Section 4, Precision Strikes, exploring biologic therapies. If conventional DMARDs are the infantry, biologics are essentially our special ops snipers. Instead of just broadly suppressing the whole immune system, they target extremely specific microscopic pathways. Now, I know the drug names are a bit of a tongue twister, but their functions are seriously incredible. You have TNS inhibitors like etanercept, which block the TNF-alpha cytokine. Then there are T-cell blockers like abatacept that interfere with CD28 activation. You've got B-cell depleters like rituximab and interleukin inhibitors like tocilizumab. Bringing in one of these precision agents is very often the game changer needed to secure a victory over severe inflammation.
Next up, Section 5, Managing the Crossfire. Let's talk about the day-to-day symptom management. So there's an absolutely vital distinction here between just feeling better and actually getting better. A lot of patients naturally rely on NSAIDs or corticosteroids for relief, but you really have to think of these as fire extinguishers. Yes, they put out the immediate flames of pain quickly, which is great, but they do absolutely nothing to prevent the underlying joint destruction. DMARDs, on the other hand, act as a heavy shield. Sure, they have a slower onset and take a while to kick in, but they are what actually alter the disease course and halt that irreversible damage.
And in reviewing all these treatments, I quickly realized that this pharmacology is basically an alphabet soup of risks, side effects, and complex drug interactions. That's exactly where the pharmacist steps in, as a really crucial tactician. They are the ones navigating these complicated DMARD and biologic dosing schedules, constantly monitoring for severe adverse events, double-checking interactions, and even helping to manage the sky-high costs of RA pharmacotherapy so that the treatment strategy is actually sustainable for the patient.
Finally, we arrive at Section 6, the treat-to-target strategy and structured care. When battling RA, you can't just wing it. You need a strict, structured timeline. On day 1, a DMARD is initiated. Fast forward to month 3, and doctors rigorously evaluate both tolerability and efficacy. By month 6, if the target disease activity or remission hasn't been achieved, therapy is escalated. But here is a super critical warning for the post-6-month period. Even if a patient successfully reaches remission, stopping medication must be an incredibly slow, stepwise taper. You can never, ever just walk away from this battlefield overnight, or you risk a catastrophic flare-up. Which brings us to a final, really provocative thought. We learned earlier that those ACPA antibodies can show up a full 15 years before the disease clinically strikes. So the question I want to leave you with today is this. If we can predict the immune system's confusion a decade and a half early, could future medical science eventually intervene and stop this invisible war before the very first joint ever even aches? It's an absolutely fascinating frontier for rheumatology and one that offers immense hope for millions of people. Thanks so much for joining me for this explainer. I really hope you walk away today with a much clearer understanding of the hidden battleground of rheumatoid arthritis. See you next time.